All right, good morning, everyone. Thank you for joining us. I am Jess Morley. I'm the policy lead in the University of Oxford's Data Lab, which is headed up by Dr. Ben Goldacre, and we use big data to do practical applied analytics in the healthcare service, whether that be things through our services such as openprescribing.net or more recently Open Safely, which is a large electronic health records analytics platform, which we have mostly been using to do an analysis on COVID for the last year, which sounds strange to say, but that is the truth at this point in time. And we are also currently running a review into the better, broader and safer use of health data for research and analysis for the Secretary of State, Matt Hancock. And I think what has become really clear during that period, that both process, is that we're in an incredibly exciting time for the use of health data in England and in the UK. We seem to have really reached a sort of watershed moment where people are understanding the importance, are willing to have more difficult conversations than have previously been had about how we can enable this, how we can make sure data use is safe, and how we can make sure that the population benefits at large. So how we can tackle inequality issues, how we can tackle population health issues, and how we can make sure that the use of data is both trustworthy and safe, but is also being used in an efficient manner, so near real time at a large scale. And I'm absolutely delighted to be joined today by Jonathan Craven, who is the Head of Information Governance and the Data Protection Officer for the Central and North West London NHS Foundation Trust, and Alistair, who is the Product Manager for Open Data and Data Visualisation at NHS Digital. And I'm really excited to hear what they have both got to say for us. So without further ado, I am going to hand over to Jonathan, who will do a little introduction for us for the next 5 minutes.
Good morning. Thank you very much. It's really nice to be here. And thank you for that introduction. I suppose a little bit about me and a little bit about my experience over the last year. So I've spent most of my career working in data protection, information governance across the public sector. I've worked in, I suppose, some might more call the Holy Trinity. So I've done local authority, NHS and police service. So I've got a really, really broad range of experience of kind of data and information management and the data protection issues across all those fields. I think it's really, really appropriate that we're having this conversation today, a year and a day on from the first lockdown day, because it's a really good time for reflection on a year of unparalleled change and development in the NHS, in most organisations, I suppose, and indeed probably almost every aspect of our lives, let alone sort of working lives. Certainly from my experience, one of the major things I noticed was over the last 12 months, we've observed a lot of programs of work which were originally planned to take years to come to fruition have actually been implemented in a matter of months, if not weeks in some cases. We've seen, as you said in your introduction, we've seen NHS organisations embrace technology like never before. We've seen ways of working which have been embedded for years and years and years change, and in some cases completely disappear overnight. And I suppose I could spend 5 and indeed 50 minutes talking about all of the improvements that we've seen, but in truth that's probably only half the story. And I think this is probably one of the interesting things about the conversation today, because in spite of, as well as all of the development and innovation that we've seen, all the unprecedented change and upheaval, all of the improvements, we still find the NHS, I think, still finds itself with a fundamental dilemma, which is we are striving to be a 21st century organisation. We want to embrace the principles of digital first, of paper free, being aware and responsive to what patients' needs and preferences are about their care pathways and how they access services. But at the same time, the NHS as a whole is an organisation with quite a difficult and complicated legacy. There have been years of under or misinvestment in IT infrastructure, in software as a service, in new healthcare tech, in compliance and governance tools. And we are at a time now where there has been unprecedented investment, but there is still kind of a lag, a backlog of how do we bring everything sort of up to code, as it were. I think there's also been a fundamental shift in the last few years, and this is not really COVID dependent, but on requirements for compliance with data protection legislation and other legislation, and the additional resource that is required to achieve that. And I think at first glance, that's not something that's necessarily been mirrored by a change in approach from all senior leadership across the NHS as a whole. And I am making a generalization here that we need to move the argument on from being, do we spend money on patient care or IT? When in fact, actually, we need to spend the money on both, and we just need to work out how we're going to do that. And I think really, hopefully, as part of this conversation, if we'll go on to discuss, if we spend the money correctly on one, the other one will actually follow. I still think you're right from your introduction that there has been new conversations are being had. People are prepared to have those kind of difficult conversations we might have not had previously, but I still think there's a relatively low level of understanding and awareness of something like a data protection by design approach, which is how we're going to use data safely, how we make sure that it's accurate, that it's timely. And I think how the lack of understanding and awareness probably extends to people's understanding of people's responsibilities, and that this data protection and good governance around data is not just the sole remit of IT or data protection or IG, as myself. Actually, it's every staff member's sort of remit. So I suppose really, I feel that we find ourselves, the NHS finds itself at a time of unprecedented opportunity about what we can do. We can become an organisation that's fundamentally driven and underpinned by really accurate, timely data, which provides insights we've never had before. But if we're going to grasp that properly, we really need to have a frank and honest conversation and a response to what we still have to deal with in terms of our legacy.
Absolutely. Thank you, Jonathan. You raised some really fascinating points there that I'm really keen to come back to. But first of all, I'm just going to let Alistair from NHS Digital also give his opening remarks. So Alistair, over to you.
Hi, Jess, and thank you. And that was really interesting, Jonathan, to listen to as well. So I'll start with a very, very brief bit about me, and then sort of talk about what I've been involved in over the last year, which has obviously been COVID related, as it has for many people. So I joined the NHS a year and a half ago. So I still have a lot to learn and getting my head around a lot. Prior to that, I spent 10 years working in telecoms with data and analytics. And I think I was sort of reflecting on before this call, I was thinking, I think I've probably spent my entire career trying to make big organizations do things with data. And I think that's my passion, because I think the ability of doing things at scale in a large organization, the impact it can have can be great. And I think even though the last year has been incredibly challenging, especially for people working on the front line, is that we've, from a data and IT perspective, we've achieved so much. I mean, obviously with the anniversary, sort of had to reflect with my team on our stand-up this morning, we have over the last so I spent a lot of time building our business intelligence data viz capability, both open and sort of what I'd call semi-open, so private and controlled, as well as stuff that's secure and patient level, and trying to work across that data spectrum. From in March last year, we stood up our first dashboard in the open space for COVID, which was 111 triages where COVID was suspected. And this was pre-testing, and that was quite an important data point at that time, because it was one of the few places that you get a sort of an understanding of maybe what's going on, and we could break that down to a fairly local level. And that was our first dashboard, and it was built in a massive rush in about a week and a half. It would usually take 4 times that, right? With all the governance wraps, and that's fantastic. And then we started publishing stuff around the shielded patient list, and then in the summer, we supported test and trace, building an outbreak analysis tool for local government that was rolled out and is still used now by about 75% of public health teams and local authorities. We built other open data sets of coronavirus in your area, sort of bringing stuff together and hopefully in an informed way and presenting that out to the public, as well as we built some internal sort of analytics and dashboards of cohort selection for some of the COVID trials, which again feels like fantastically valuable. And I think looking over that last year, what we've done in NHS Digital is, okay, we've done a load of infrastructure stuff. So we've deployed Tableau, we've set up all our various environments, integrated into the website, integrated into our data things, build a load of pipelines. But I think the really cool thing is kind of the people that we pulled in and built up. So it started out way back in March in terms of like, some consultants, some really, useful help from Goldman Sachs, BCG, various others. We've actually now had to build a small permanent team now that's supporting and building this. And we're now looking at post-COVID use cases around GP appointments, as well as some very much COVID-related ones around vaccinations. And I think, I guess over the last year, I mean, we've achieved a lot, and we hopefully we've had, I think we've had an impact and have helped the wider system. But I think now the real challenge is how do we keep that speed up so that we don't slow down? Because I feel like, we've achieved more, certainly in my, if I was being parochial in my career, I feel like I've achieved more in the last year than I did in the previous 5, which is great. So how do we keep that speed up, and how do we keep that sort of collaborative way of working together? Because I think what was really good at, certainly in the summer, which was particularly intense period on the data viz and getting data out in HSD, it felt like organisations didn't really exist with the PHE, test and trace. Loads of people across NHS Digital, consultants, some people do pro bono work. I think that way of working really flat is really good. I don't want to lose that. Also felt we were making risk-based decisions on delivery, and I think that was fantastic. It was it's like we'll go this out and then we'll because it needs to be out in the next week, we'll take some risk and we'll manage that as best as we can. And do you know what? Nothing went that wrong, and we kept that pace up. So I think that changes sort of risk appetite when it comes to technical delivery. Obviously, bearing in mind, impact on patients and all the rest of it. I think it's good because I think it keeps that speed up, and we've learned faster. Which I think has been fantastic, really. So in many ways, I think the last year has been been really fruitful on data analytics and NHS Digital. I feel like we're way more mature than we were 5 years ago. We've got an entire team that just didn't exist. We've recruited people externally from other industries. We're getting lots of unique viewpoints. And I think, Jess, to your point at the beginning, when you say it's a really exciting time to work in data analytics in health, I really think it is. I feel like it seems to be so central to so many sort of projects, vaccinations, testing. There's the great gov.uk dashboard that is also I think is still getting better and better. The public get it. I think more people talk to me talking to some nurses in GP practice around vaccination. They get it as well. It's fantastic. So it feels like now is the time to maybe take a jump in digital maturity, which is why I'm really happy I've joined the NHS. Really, I think the third point I say, that I think it's really different. It is the sort of values to feel that working towards common good, and I think that gives us in the public sector a really unique sort of offering. Certainly when I've been recruiting grads or when we've been looking to work with other parties, I think it gives us a really sort of unique play that you don't have to be a digital native to maybe be a bit of a front runner in data analytics, and can we innovate really well in the public sector and do that well? And I think that's something else I've sort of become quite passionate about in the last year and a half, really. So that's me. So yeah.
Alistair, it sounds as though, as much as you are glad to have joined the NHS should be glad that you have joined the force too, and bring all this knowledge to the front. So there's a couple of things that so please, if you're listening, please do put some questions in, and I'll try and make sure we ask them to Jonathan and Alistair. But there was a couple of things that I wanted to pick up on. So Jonathan, to you first. I think one of the reasons why COVID has been potentially so interesting and has been a way of moving some of these conversations forward, it's not only just because it was a crisis and we had to respond, and because Alistair picked up on, the risk appetite changed because it was like we have to do something now. But there was also something I think quite powerful about the fact that it's brought the conversation between data and patient care and real life impacts much closer together. We've had conversations now in the public about this is a data visualization of the number of cases, and this therefore is the interaction that has on your life. And there was something that you said that I thought was really interesting in your opening spiel, was we need to stop treating IT spend and spend on patient care as separate things. And one of the things that's come up a lot during our conversations about sort of the Goldacre review and things like that is that it's not always directly obvious that the NHS does research on itself. We do operational research, we do research and analysis on variation in care and how we can best optimize pathways. And so I would be really interested to hear some of your views on how we can use data to get better insights into improving and patient care pathways, and how that might trigger some of those pragmatic conversations around legacy IT and why we should spend money on that as much as we should spend on patient care.
I suppose I can come up with two sort of thoughts about that. My first thought would be sort of the negative impact of poor data curation and poor data sort of quality is all of the issues that brings, and there are impacts on the organization itself. So for particularly from my remit, if you've got stuff on the electronic patient record where you've got patient details which are wrong, you might end up sending information to the wrong address or sort of things like that. So those very, very avoidable kind of data protection issues that are just down to poor data quality. And I think that for me is that really it feels like one of those conversations that we should have had already. And it's just this kind of, and I think it's probably because it's not a catastrophic failure that it just rumbles on in the background and people kind of acclimatize to it and go, well, that's just how it is. And I think one of the things that we've highlighted probably in the last 12 months is actually there shouldn't be a threshold of acceptance for poor data quality. If anything, it should be incredibly low. We shouldn't just say, oh, well, there is like this tolerance of it's actually, we know it's wrong, we know it's wrong, and we're not going to do anything about it. So I think that's the first thing, is that they do have these impacts, both on the organization and indeed on the patient care as well, because if their details are wrong, how on earth can we say that we're going to give them proper care? But I think one of the really exciting things for me about use of data going forward is actually where we're looking to use, for example, wearables or patient self-monitoring of healthcare, and how we're going to integrate that into the electronic patient record. So what we're going to be able to do, for example, we're going to be able to do blood pressure monitoring or diabetes and insulin uptake monitoring, things like that, for patients who are going to be able to provide the clinicians with absolutely real-time data and a vast amount more data than they could possibly get from a weekly, monthly, quarterly blood test or whatever. And I think it's actually having the vision to say, we shouldn't be scared about patients having direct access or direct input into their patient record within certain constraints. We're not basically giving them free and unfettered access to go and rewrite their patient record, which I know is something which feels sort of, when I've had the conversation with clinicians about patients having access to their own records, I tend to get sort of a reaction of utter horror. But actually what we're not talking about here is basically, as I said, just giving the keys to the kingdom and saying, go and rewrite your notes. What it is saying, actually, now we are working in an environment where my Apple Watch can give my GP information about my health much more readily than either I can, or indeed district nurse could, or the doctor themselves could. So actually, we shouldn't miss a trick there to say, we've got data there. It is available already. We really should be using it. And I think it's one of those things where this isn't something, we're not talking about science fiction here. The technology is there. We can do it. We can join it together. We know because it works. So really what that next step is, and I think this goes back to some of Alistair's points about this change in the risk appetite, is saying, actually now is the time to use these kind of things and leverage these kind of programs and say, look, we can get huge benefits out of this. So let's do it.
Yeah, and that's absolutely. And I think there's a couple of things in there that were super interesting. So one thing, and I don't think we have this conversation enough, is that the more data is used in health, more health data is used, the often the more accurate it gets. You know, if people are not looking at it, people will never know that it's incorrect, and therefore they will never go back and check it. So we've had instances in Open Safely, for example, where we have seen that people have died twice. Clearly, you don't die twice; you die once, and then. But there are less obvious errors than that. You know, people being coded. We've had a couple of instances where we've seen people show up as being pregnant when they're 75-year-old men. So there are inaccuracies there, and they can be sort of solved by more people having access to the data. So both coming at it from both of your perspectives, I suppose we have experience in two things that you've both picked up on. With openprescribing.net, we are working with open data. So it is data that is in the public domain about the number of prescriptions given out in the NHS, and that is something, the data is at aggregate level. It's very limited in terms of its disclosivity, and so we take the approach interactive, and we use visualization to give people more tools in order to interact with it. With Open Safely, we take the opposite approach, and this is something that Jonathan, that you mentioned, where we take a privacy by design. So we work on both a sort of federated model and a differential privacy model to send the code to the data rather than bring the data to the code, and that enables many people to be able to use and run an analysis over electronic health records, because the data stays where it is. We never move it, and so even though it's highly disclosive, no one's ever actually seeing it. And so I would be interested to hear from both of your perspectives, how do we, balancing those two things or different approaches, give more people access to health data in a way that can help us unlock all of these benefits that we have been discussing about thus far? Either of you jump in.
Yeah, I think that's really useful. It sort of triggers a sort of two thoughts, I think, immediately. I mean, the first one, I think, that leads on from what Jonathan was saying is, you know, how do you get people using that data, and how do you improve that data quality? And there is this virtuous loop, I think, that goes on when you're using it. You care about it, you improve the quality, and I think sort of, you know, my experience today, I think you can start off with some super granular use cases that are really specific. So, you know, we're doing some stuff at the moment around GP appointment data. It's very specific, just, you know, that data's gathered. Okay, happy days. So what we're going to do is present that via some data viz back to the practices so they can actually view it, scrutinize it, and then we can start, you know, then we can start using it for more advanced analytics. So I think there's definitely, and I think there's no shame in starting like in a really specific use case and then scaling out. And that's easier than trying to write a strategy and come down. I've certainly made that mistake in previous roles, right? It's just really hard to make happen, even though maybe senior people get very excited about it, but actually making it happen on the ground is challenging. So I think there's that point about it's okay to start super granular. And I think your point around sort of, you know, take the code to the data, which I think is really powerful. And there's obviously some assumptions there around sort of common data models and how that works across domains. And there's lots of, you know, quite interesting sort of data architecture type questions. I think one of the things that struck me is sort of how do you get that community around that open code? I think is really important, because I mean, I'm constantly struck by I stumble across people in NHS Digital or NHS England or Test and Trace or you know, at Leeds University, and do a lot of stuff around health data there as well. And there's just so many people that know the answers usually to the questions I've got, or have tackled it before and have got the bloody toes from where they stubbed them. And I think that it is sort of how do you connect around that? And then I think the open code comes after that community almost, would be the way I'd view it. But it, you know, and I'm you know, and I think it's how do you sort of connect all those many tendrils and communities right across the NHS and outside as well. So I'll pause there. I don't want to take up time, but I think that's, yeah, sort of two thoughts.
Well, I'd just like to build on one of those particularly, I think, and this is not just about data, but I suppose this is kind of my approach to the whole data protection compliance piece in the round, is making it relevant to people will make them more likely to do it. Simple from my experience. And I think the point you've just made there about making the data usable is much more likely to make people care about it more. Therefore, they are going to make sure that the quality is better. And as you say, it's this virtuous cycle of actually, this is really useful to me, but if the data is rubbish, it's not useful to me. But it would be, the insight would be, if the data is good. Therefore, how do we get the data good? So I think, and I think that's been one of the, and I think this is still one of the biggest challenges. I think we're a lot better at it now than we were probably 12 months ago. But I think as an organization as a whole. And I appreciate this is a very, very broad generalization, but I think it's just that appreciation now of saying we can do these things. We know we have the technology, we know we have the people who can do it and it can implement it, but what we need to do now become business as usual, not some kind of fancy bolt-on to a system or a process. Is actually we need to socialize these things and make them normal. And I think this is, again, I reflect specifically on my approach to data protection, but actually saying there's no point trying to get people to do compliance work as an add-on to their day job. It needs to be part of their day job. And I think this is when we're talking about improving data quality, using data, something that's going to be, oh, well, hang on, if I remember to do that at 4:30 on a Thursday, all right, well, I might spend half an hour on it now. It needs to be something that they're doing every day, day in, day out. And I think we will get there, but I think it's one of those things, it feels to me very much like it just needs to build up that kind of critical mass to get to a point where we're actually, everybody goes, and I do genuinely feel we are probably as a whole organization or continuum going to have a light bulb moment at some point. And people are just suddenly going to go, oh yeah, that makes sense. Why don't we do that more? And I think what you're saying, Alistair, is that having those conversations with people across other organizations, when you suddenly think, actually, people are doing this already. It's not, I am not the lone voice in the wilderness. Actually, people are doing it all over the place. And we just need to start joining this up and making it more, A, more widely known, and B, more socialized. As I said, I think really just to say to people, look, this is perfectly normal, and it's actually really, really helpful.
Yeah, and I think there's always there's a balance to be struck, I think, with that sort of like connecting the hive mind, which is like quite abstract and really, really useful, and then the real granular use cases that I think, you know, actually instigate change. And I think that's something I find really hard is, you know, there's all these people that know stuff, let's go and talk to them and learn, and isn't this fantastic? And I can go off and have lots of fun, but then the problem is then, okay, well, how do I take that and go and solve a very specific problem that's going to go and make, you know, a patient or a clinician's life a lot easier? And I think it's sort of like connecting those two things. If you focus too much on a specific problem, you know, you forget there's this world out there that sort of, if you spend all your time just looking at that wider world, you just get into analysis paralysis because the problem is too hard. And it's that's a constant battle I have, and I get it wrong. But I go one way or the other all the time. So it's kind of like a weave.
I think the weird thing from my perspective is as well is that sometimes it does take that actual the granular use case to be the sort of what proves the exception that proves the rule, because actually I think one of the most interesting things from my experience over the last 12 months was for having so many conversations for a very, very long time with primarily with clinicians who were always saying face-to-face appointments are always the way to go, cannot use technology, can't do it, won't work, isn't going to be the thing. And yet 2 or 3 months after March of last year, so sort of summer of last year, virtually every single clinician I spoke to would become a digital evangelist, had basically just said, I want to do all my consultations remotely from now on because it makes everybody's life so much easier. And I think, as you say, sometimes it's actually having that use case work that you can then build on that and build on that and build on that, because then you make converts of people. And I think in the data arena, it's when you show them that the data is beneficial to them, or the use of the data is beneficial to them, that you stop having to try and persuade them, and they actually go off and do the persuading themselves of other people.
Yeah. And I think, like, you know, I guess as somebody who's on more on the delivery side of things at the moment, and, you know, I've got lots of IG colleagues, those, you know, when we get into those specifics, it makes those IG conversations really constructive. I think, you know, to your point, because, you know, I remember when we had a conversation around sharing postcode level information for testing, right? And we had, you know, some public health people saying it helps them position some of their sort of community engagements, but also sort of roving testing vans at that point in various areas, sort of inner cities, and having that real granular use case. So we need that data because, you know, XYZ from these local authorities need it to position their vans where they're going to carry out testing, and these cons suddenly made the conversation very easy in a way, because I could, you know, you could see the value of it, of what we were trying to do, and understand that purpose. I think that again is like I think makes that working with governance much more easily, again, when we're on those real granular use cases, as I think the wider overarching ones are always much harder to sell. But I think we'll get there, but we'll build it up with all these little building blocks of, the good stuff we can do with specific data sets. Sorry, Jess, I'm seeing you.
No, I'm just I've been very much enjoying the conversation. I'm just aware that we've got 90 seconds left. So I was going to wrap up and ask for some sort of 10-second final thoughts. So for me, I think, and this is a question that's come up in the panel as well, is there something very powerful about these conversations around making data more useful, making it more widely available, building community around the use of data, and opening up analytics for collaboration to enable a ratcheting effect and to enable an innovation sort of cascade of more people doing things with the data, but also because it makes things meaningfully transparent for patients around what is actually being done, who is accessing the data, what for, and what is the direct care benefits that happen as a result of that. And we don't often have that join up. And I think we're finally moving to a world where we can make that connection between I have a patient, I've been to see my doctor, I get something coded in my record, someone does something with that data, and that results in improved care. And I think that's going to be incredibly powerful, and I'm excited to see it happen. So any other last thoughts from either of you?
I suppose very, very briefly, it feels to me like we are at a time of huge opportunity. And I really, really hope that we can build on it. I do believe we will. I really do think we need to build on it now. Yeah.
All right. Thank you. I think we are ending, but thanks so much for your time.
Thank you.